can lead to bad outcomes for our patients. Ryan, this probably gives you some PTSD looking at this slide. This is a fairly complex topic, but I think a really, really important one, and one that we're just getting more information or more understanding about. And unfortunately, this deals with an animal model, which makes sense when I start talking about what the actual study did. They were actually able to implant pressure transducers in the dependent areas of the pleural space to measure very localized pleural pressures in these animals, these pigs, to get an idea as to what local pleural pressure was. And by looking at pleural pressure, then you can better define driving pressure from the ventilator to the alveolar pressure in that localized region. They also placed esophageal balloons in the patients. Some of you may be familiar with esophageal balloons. Not many people are using them anymore. But the esophageal balloon has always been a marker of global pleural pressure, with low pleural pressures being associated with higher driving pressures. Just asking, how many people have used esophageal balloons in their careers? One. All right. Again, as evidenced by how sort of unuseful it is. And one of the reasons they may be unuseful is what I'm about to go through. All right, that they may not be such a good marker of true pleural pressure in our patients. What they found, and then what they did is they measured both esophageal pressures as well as, and that's in black, versus the local pleural pressures in the dependent injured lung zones. And they induced ARDS in these pigs, by the way. And then they gave the pigs rocuronium, so they paralyzed the patients. And initially, before the pigs were paralyzed, what you saw was that esophageal pressure goes down as the animal initiates a breath, and as they get paralyzed, then there's less and less effort from the animal, and therefore esophageal pressure doesn't go down as much as it did in the spontaneously breathing patient or animal. But what was really interesting was looking at the dependent pleural pressures. Is they actually had marked decreases in dependent pleural pressures in the spontaneously breathing animal that goes away when the patient, or again animal, is then paralyzed. And that these localized pressures are much, much lower than the esophageal pressures. Again, hence why the esophageal pressure isn't a good marker of local pressure changes. And really what that is showing is that the transpulmonary pressure from ventilator to alveoli is much, much higher in a spontaneously breathing patient or spontaneously breathing animal than one could detect from our usual clinical means. Obviously, we're not going to implant these pressure transducers in our patients with ARDS. They did take the study one step further, and these are now human CAT scans. And patients that were spontaneously breathing, we can see that their tidal volume recruitment is about 15%, and in the paralyzed patient, the tidal volume recruitment is about half of that. Again, you can see much less air in the lungs. That sort of sounds like that's a bad thing, right? We want to get more air into the lungs of our patients, but again, what we know is that controlling tidal volume is important. And what's happening in these spontaneously breathing patients with ARDS is we're actually developing alveolar overdistension in those dependent lung regions. And again, even though the total tidal volume is set, the distribution of that tidal volume is different in a spontaneously breathing patient compared to a paralyzed patient. And that additional respiratory effort can lead to overdistension of those lungs. So worker breathing matters. If the patient is working harder, they have higher potential for injurious lung distributions. So what makes a patient work harder? Well, it's respiratory drive. And what are the factors that result in someone's respiratory drive? Well, we sort of like to make it very simple. Well, it's PCO2 or pH maybe, and that sets our respiratory drive. And really, it's a lot more complex than that. Other things can increase one's respiratory drive. Stretch receptors in the lungs, certainly relevant to respiratory drive. Inflammation, that's hugely important for critically ill patients. Many of our patients have inflammation and therefore have increased respiratory drive. Pain, anxiety, fear, all those things can sort of increase one's respiratory drive. And metabolic demands, including lactic acidosis that we talked about, can also increase respiratory drive. And we know that excessive respiratory drive exists in many of our critically ill patients. In fact, the majority of our critically ill patients have an abnormal increased respiratory drive. That imbalance, that increased respiratory drive with a normal ventilator set is going to be an imbalance that's going to result in asynchrony. A really important thing is that normal gas exchange does not exclude asynchrony, again, because there's so many other factors that result in respiratory drive. Gas exchange is only part of that. And attempts to normalize gas exchange may actually worsen asynchrony because you're ignoring the other aspects of respiratory drive. A diagrammatic representation of that is that we have a set respiratory drive here in the white line, and in a normal situation we have other factors beyond gas exchange and CO2, a normal being 40, results in a respiratory drive that's equal to what's being delivered by the ventilator. In a patient with sepsis, those other factors, inflammation being a key one, are going to be increased. And so even though that person's CO2 is 40, they're going to have an increased respiratory drive that isn't being met with this, the set ventilator that was normal for a normal patient. What we can do is sedate the heck out of the patient or paralyze the patient. Paralyzing takes away someone's respiratory drive pretty quickly, or at least the effect of it. And that can help get things back into synchrony, but excessive sedation and excessive paralysis certainly has downsides as well. So that may not be the best thing for our patients, and in fact it may not be very easy to achieve, and we'll talk more about that too. But what we can do in that patient with increased inflammation and other factors, we can actually blow off their CO2 even lower than 40 to what will be a very abnormal CO2, but that will decrease their respiratory drive so that they can achieve synchrony. So this is an important thing to think about. If we're trying to achieve a CO2 of 40, that may actually lead to more asynchrony in our patients. The problem is we don't know what CO2 to set for, right? We don't have a number to say, well, go for 26 in septic patients. What we have to do is we have to look at the ventilator. We have to look at the waveforms and see if the patient has asynchrony. Again, this idea of blowing off the CO2 to 26 is the concept of overdrive. And everyone in this room knows that the way to increase more CO2 is to increase minute ventilation. And you can do that through increasing tidal volume, which we've already said maybe we don't want to do, or we can increase minute ventilation by increasing respiratory rate. Again, part of why we say set a respiratory rate at a high rate rather than a normal rate for our patient. And ultimately, we do need to match the flow that the patient demands and match the inspiratory time or neural cycle that the patient demands. Let's go back, look at another patient. That was a lot of talk about science. Let's look at this patient and look at their waveform and see what you think. Is this person passive? Yeah, I think people are waking up. This person's passive. What else do we see in this person's waveform? Well, one thing not in the waveform, but I see a peak pressure of 43. Why do we think that person's peak pressure is 43? Anything else that we can see going on there? 460 tidal volumes. Well, so we don't know how tall this person is. That does seem pretty big, but probably for someone who's about 6'2", that's not a bad tidal volume. If this person's 5'4" and female, that'd be a really bad tidal volume. Very good. One thing that I see is maybe this expiratory flow. I didn't hear you. High PEEP. There we go. PEEP 20. Yeah. There we go. So PEEP at 20 certainly is contributing to that peak pressure of 43, no doubt. And I also find, despite the set PEEP at 20, that inspiratory flow is not quite going back to zero in many of these patients, or in this patient. In fact, when we look at that patient, We decreased the patient's PEEP for whatever reason and did a nice expiratory hold and decreased their respiratory rate as well, and found that this person, despite the flow tracing finally getting what looks like zero, expiratory flow is really happening for many seconds afterwards. And so not only was the PEEP set high, even if we take the PEEP away, this person's PEEP is going to be persistent because of slow emptying time. And in fact, once we really hold that expiratory hold, we actually find that PEEP starts rising as we finally get better transduction. And again, this is now approximately 12 seconds after that last breath. We see a PEEP of 17 still in that patient. So a patient with significant obstructive lung disease resulting in increased PEEP, increased auto PEEP, and therefore increased peak pressures, but also plateau pressures. Finally, many seconds later, another breath or emptying finally occurs. Again, about a 20-second expiratory time for this patient. Sorry, this is not a high-resolution graphic from a ventilator, but rather from a publication. What do we see in this person's tracing? Now, recognize that this is different than our servo ventilators, maybe different than the ventilators that other people use, but flow is up on top, pressure is down below, with volume down here. Let you guys take a look at those tracings for a minute here. One of the things that I see is things related to what we call trigger asynchrony and ineffective triggering. IT is ineffective triggering. In the flow here, we see that the patient is actually starting to create flow towards the patient, and we see a dip in the pressure here, but the machine doesn't deliver a breath. So the patient is trying to take a breath, but nothing gets delivered. We see the same thing a breath and a half later. And we also see one a couple more breaths down the road. These are all examples of trigger asynchrony or ineffective triggering. So trigger asynchrony is defined as failure to deliver a breath despite patient effort. And it occurs when the negative pleural pressure is insufficient for the patient's alveolar pressure and the set PEEP. So whatever pleural pressure they're generating is not less than the person's actual alveolar pressure. We know that ineffective triggering can occur in up to 25% of patients in the ICU, most commonly in patients with obstructive lung disease. We expect that. Something that we don't necessarily expect as much is in obesity. A lot of obese patients will develop trigger asynchrony, in part because they may actually have increased pleural pressures or increased alveolar pressures related to their chest wall weight. Usually trigger asynchrony is preceded by a large breath, so again, not having enough time to exhale, resulting in auto PEEP, and shorter expiratory times, also known as increased respiratory rates. Are associated with trigger asynchrony. Again, for those that don't think about this a whole lot, sort of normal respiratory physiology on a ventilator, we have a set PEEP of 5. So in a normal patient, then the alveolar pressure is 5 at end expiration. And the pleural pressure is a little bit lower than that. Maybe about 1 for most patients. And again, there's elastic recoil of the lungs that sort of sets that difference between alveolar pressure and pleural pressure. But when the patient takes a breath, pleural pressure goes down to -4. That's a pretty small effort, but some effort. And when pleural pressure drops by 5, then we expect the alveolar pressure to drop by the same amount, by about 5. And therefore we have flow, and I'm sorry, my mouse is being tricky here. So we have a PEEP of 5 and an alveolar pressure of 0. That's going to initiate flow into the patient. What happens in other situations is when alveolar pressure is 15 because of auto PEEP, as the pleural pressure decreases by 5, the alveolar pressure decreases by 5, but the alveolar pressure is still higher than the PEEP, the set PEEP on the ventilator, and so we don't have flow going into the patient. And that will result in ineffective triggering. Despite the patient's efforts of reducing pleural pressure, it's inadequate to develop flow from the set PEEP to the true alveolar pressure. Ways that we can address trigger asynchrony is to decrease alveolar pressure through more time to exhale. We can increase the set PEEP. And again, in this person with an alveolar pressure of 15, if we set the PEEP to 15, then that same pleural effort results in an alveolar pressure of 10, and now we have flow into the patient. So increasing the set PEEP will actually improve trigger synchrony for our patients, and really won't change the alveolar pressures. So it's not going to result in lung overdistension because the lung was already at that pressure. What we're just now creating is the difference between the ventilator and the patient that results in flow. Sedation can help, again, by helping reduce respiratory rate,